Finals SAQ35, tongue cancer. A 54-year-old patient with base of tongue cancer presents for a hemiglossectomy and radial forearm free flap reconstruction. A. Which specific factors must the anaesthetist consider when assessing this patient prior to surgery? Specific factors asked includes the patient, the pathology and the surgery. The stereotypical patient with tongue CA is a smoker with high alcohol intake, malnourished due to alcohol intake and oral cancer, and may have had radiotherapy and chemotherapy, leading to malnourishment and difficult airway. A. Airway. This patient may have a difficult airway due to the tumor and any preceding radiotherapy. Patients who have had previous surgery or radiotherapy may have fixed, thick, soft tissues and poor neck mobility. Intubation may be harder than predicted by bedside tests. Consider video laryngoscopy, awake fiber optic intubation, and awake tracheostomy. Heavy smoking is associated with poor gum health and teeth health. There is risk of dental damage during intubation. Respiratory. This patient is likely to be a smoker. Assess for smoking-related lung disease such as COPD. Smoking also increases the risk of flap failure. C. Cardiovascular. Smoking is associated with atherosclerosis, ischemic heart disease, peripheral vascular disease, which increases risk of flap failure, and hypertension. Treat accordingly, if present. High alcohol intake is associated with arrhythmias, dilated cardiomyopathy and hypertension, and risk of autonomic dysfunction leading to CVS lability. Treat as appropriate if present. Consider CVS effects of preceding chemotherapy, such as cardiomyopathy. Vascular access site will be determined by the donor site. Ensure confirmation of planned donor site with surgeon before any cannulations. Neurological. If high alcohol intake, assess and treat for alcohol withdrawal and Wernicke-Korsakoff syndrome. Smoking increases the risk of stroke by 2 to 4 times. Gastrointestinal. Risk of poor nutrition is associated with high alcohol intake, oral cancer, and chemotherapy. There is high risk of poor wound healing and flap failure. Consider pre-op PEG placement to optimize perioperative nutrition. If high alcohol intake, this is associated with alcohol liver disease, which affects drug choices, pancreatitis, treat if present, and gastritis, avoid NSAIDs. Hematology. There is risk of anemia, which is associated with high alcohol intake, malnourishment, or chronic disease. This reduces wound healing and flap survival. Prolonged surgery leads to increased risk of deep vein thrombosis. Ensure prophylaxis is given. If high alcohol intake, this is associated with thrombocytopenia and leukopenia, which may increase the risk of bleeding and poor immune function. Infection and immunity. Comorbidities, heavy smoking and high alcohol intake increases the propensity to infection. Assess for infections and treat appropriately. Cutaneomusculoskeletal. This is often a very prolonged surgery, which may be performed on a malnourished underweight patient. High alcohol intake is associated with peripheral neuropathy, leading to possibility of pre-existing wounds, myopathy, osteoporosis, and osteomalacia. Smoking also increases the risk of osteoporosis. Provide meticulous attention to positioning and protection of pressure points. Metabolic. Prolonged surgery leads to risk of hypothermia. Provide warming mattress, warm fluids, core and surface temperature monitoring. High alcohol intake is associated with hypoglycemia, hypomagnesemia, and hypokalemia. Treat accordingly. Heavy smoking is associated with type 2 diabetes mellitus. Assess blood sugar. Psychology. Patient anxiety may be present due to potentially life-changing surgery. This may require pharmacological or psychological management. A review by Sebastian Pierre et al. In 2017 discovered that smoking causes 20% increase in hospital mortality, 40% increase in major post-op complications, and increase in all specific surgical complications. Anticipate and treat complications if present in a post-op setting with appropriate level of care. B. List the benefits of a free flap reconstruction. Introduction to free flap reconstruction. An area of the body that has cancer removed could be covered by a graft or a flap. A graft consists of skin and subcutaneous tissues that are taken from elsewhere in the body and rely on development of vascular supply from the recipient side to survive. Examples of types of flaps include local, pedicled, and free flap. A local flap involves moving a chunk of tissue whose donor site lies immediately adjacent to the tissue defect to cover a defect locally, taking its blood supply with it. A pedicled flap involves excising an area of tissue and moving it to some distant part of the body whilst retaining a pedicle through which the original blood supply still flows. For example, transverse rectus abdominis muscle flap. In a free flap, the tissue is completely removed from the donor site and its blood vessels are anastomosed at the recipient site. Problems with using a graft includes a graft of skin and subcutaneous tissue alone will not give the functional or cosmetic result of a flap in this case, nor will it necessarily develop sufficient blood supply to survive when covering such a large area. Problems with using a local or pedicled flap. There are no suitable nearby donor sites that could provide a local or pedicled flap, especially as the use of bone in reconstruction in this patient will have is so critical to the functional and cosmetic outcome. Benefits of a free flap reconstruction in this case includes better cosmetic outcome than a graft, better functional outcome than a graft as bone is used to reconstruct a functioning jaw into which dental implants can ultimately be inserted. Lack of suitable local donor sites for local or pedicled flap, better coverage than a graft for large and deep defects, better healing and vascularization than a graft, possibility of retaining innervation as the whole neurovascular bundle can be re-anastomosed, and better coverage of delicate underlying structures than a graft. C. What are the causes of flap failure and how may they be prevented in the perioperative period? Causes of flap failure includes inadequate perfusion, flap edema, poor wound healing, poor oxygen delivery, and anastomosis failure. Inadequate perfusion. Factors affecting blood flow may be described by the Hagen-Poiseuille equation, where pressure gradient times pi times radius to the power of 4 divided by 8 times viscosity of fluid times length of tube equals blood flow. Radius of vessels must be maintained to ensure adequate perfusion. This can be done by maintaining normothermia with active warming and maintain core peripheral temperature gradient of less than 1 degree Celsius, avoid post-op shivering, ensure adequate analgesia, as transplanted arteries still respond to circulating catecholamines, consider regional anesthesia. Use of flow-directed therapy to optimize fluid management, avoid the inappropriate use of vasoconstrictors, prevent arterial thrombosis, which may be triggered by inflammation due to reperfusion after prolonged ischemic time. Avoid excessive ischemic time. There may be a need for anticoagulation to avoid arterial thrombosis. Maintenance of pressure gradient along the vessel ensures adequate blood flow. This can be done by maintaining blood pressure, close monitoring with intra-arterial blood pressure, and cardiac output monitoring. Maintain high cardiac output. Avoid extramural pressure on arteries. Ensure dressings are not tight. And install drains to avoid hematoma. Avoid poor venous drainage due to thrombosis. Anticoagulation may be required. Maintain normothermia and avoid inadequate venous drainage due to external compression. Next is viscosity of blood. Aim for hematocrit of 0.3 as this offers optimal balance between oxygen delivery and blood flow. Flap edema. Minimize flap handling, minimize flap ischemic time, and avoiding excessive fluid therapy with cardiac output monitoring reduces the risk of flap edema. To reduce the risk of poor wound healing, ensure optimum glucose control, smoking cessation preoperatively, and management of pre-existing malnutrition. To ensure adequate oxygen delivery, monitor hemoglobin and hematocrit, transfuse if necessary but ensure balance between hemoglobin level and blood viscosity is maintained. Providing supplemental oxygen improves oxygen delivery. Anastomosis failure can be prevented by maximizing surgical technique and avoiding surges in blood pressure caused by coughing or retching. Consider remifentanil or neuromuscular blocker infusion. Optimized nausea and vomiting prophylaxis. Additional information. Examiner's report. Weak candidates suggested assessment of a potentially difficult airway as the important pre-op feature, but ignored the comorbidities associated with causative factors such as smoking and alcohol consumption. The impacts of major physiological changes that are caused by such prolonged and invasive surgery were ignored. The role of the anaesthetist in influencing free flap survival was particularly poorly answered.